All right, good morning, good afternoon, good evening, people who are connecting. We'll just give everyone a couple seconds to join the call. I can see we're up to over 50 at the moment, so we'll just give everyone a couple seconds to get settled before we get started. In the meantime, for those of you who have already joined, just wanted to let you know that there is a chat function at the bottom of your screen that you can use if you want to exchange anything with us or put a little note there. In addition, if you want to say where you're from or where you're connecting from, that would be great. And there's also a Q&A button function that we will be using specifically towards the end of today's webinar when we ask for everyone's thoughts. So we're up to 90. This is exciting. And also while people are joining, just letting you know that we're recording today's session. And we will plan on making it available to everyone on our website shortly after. So please bear in mind that this is being recorded. All right. Should we start at 03? And that way we are giving people 3 minutes to have them joined. And we should be ready to go. Okay, I said I would start at 03. It is 03. I'm not going to say which time it is because we're all in different time zones. So good morning, good afternoon, good evening, everyone. It is really exciting to have you all here. And today is a really great day for us. We're coming to the close of a really exciting process, which you will hear more about in a few minutes. We're launching officially to the world our baby of the last maybe 3-4 years, the WHO Sexual Health Assessment of Practices and Experience, which we're calling SHAPE questionnaire, which is a questionnaire that promotes standardized and comparable measurement of sexual practices, behaviors, and sexual health-related outcomes across diverse global settings. My name is Vanessa Brizuela. I am a technical officer at the Department of Sexual and Reproductive Health and Research at the World Health Organization in Geneva, Switzerland, that hosts a special program for research and research training in human reproduction. And I am joined here today by a stellar panel, and I will quickly introduce them so that you all know who's coming next and where they're coming from. So first off, we're going to have Leanne. Leanne Gonzalez is a scientist working on sexual health in WHO's Department of Sexual and Reproductive Health and Research. She works down the hall from me, which includes the UN Special Program on Human Reproduction. Her research, policy, and advocacy work covers topics ranging from sexual pleasure to menopause. She has an MS-PH from the Johns Hopkins School of Public Health and a PhD from the University of Basel. Next on, we will have Erin. Dr. Erin Hunter is an assistant professor of global health at Clemson University and an adjunct assistant professor at Johns Hopkins Bloomberg School of Public Health in the US, as well as an honorary senior lecturer in the University of Sydney School of Public Health in Australia. She's a mixed methods global health researcher whose work seeks to inform the development of social and behavioral interventions to improve health and well-being. She also applies qualitative methods to develop or improve quantitative measures to strengthen survey design and program evaluation in global health. Dr. Hunter is a global coordinator of the study that she will talk about later today. Dusita Samran, and I am apologizing for the pronunciation, is an assistant professor at the Institute for Population Social Research, IPSR, at Mahidol University. Her research focuses on sexual and reproductive health, specifically on HIV/AIDS, gender and sexuality diversity, and sex work. The Institute for Population and Social Research conducted a national sex behavior survey in Thailand in 2007. She holds a master's degree in population and reproductive health research from Mahidol University and a PhD in demography from the same university. Dusita will be talking to us about the experience implementing the KOTSA study in Thailand. And last but not least, we'll have Peter Muriuki, who's a researcher with the African Population and Health Research Center, APHRC, headquartered in Nairobi, Kenya. Peter works within the Sexual and Reproductive Maternal, Newborn, Child, and Adolescent Health Unit, where he coordinates research projects on sexual and reproductive health and rights, as well as an adolescent SRH. He holds a Master's of Science in Global Health Delivery from the University of Rwanda, a Bachelor of Arts in Sociology and Psychology, and he's currently a PhD candidate at the University of Ghana, conducting a thesis on parental communication with very young adolescents on sexuality. So that goes to our very prestigious panel, whom you will hear from in a couple minutes. Just a couple housekeeping things for everyone to bear in mind. You can use the chat to say hello, share where you're from, share experiences, or basically have any sort of interaction with the panelists here, because you won't have access to microphone or other ways to communicate with us. You can also use the Q&A, particularly towards the end if you have specific questions on the presentations, and towards the end when we have a Q&A session. And you can choose different views so that you can either see everyone's faces or just the person who's speaking, depending on your preference. As I mentioned earlier, we are recording this session and we are hoping to make it available to everyone shortly after. So without further ado, I am going to give the floor to Leanne. Leanne, please take it away.
Thanks so much, Vanessa. And hello, good morning, good afternoon, good evening to everyone. I'm Leanne Gonsalves, and so my presentation is going to walk you through the process of, very briefly, of what we've done to get to today's launch, and then also introduce you to the instrument itself. As a brief history, I think Vanessa alluded to the fact that this has been a labor of love for close to about 4.5 years at this stage. And this timeline gives you an idea of some of the touch points of the process, from receiving the idea that this was something that was needed to the launch and the instrument that is available today. So back in 2019, WHO, our department, HRP Research, received a little bit of funding from the Wellcome Trust to explore data needs related to sexual health and sexual practices. Through that process, where we brought together both, we worked with researchers at the London School of Hygiene and Tropical Medicine, and also convened a set of global experts from around the world in sexual health. Of the myriad recommendations that came out of that meeting, one of them was just the fact that, there is an absence of data in this space. And more importantly, there's an absence of globally comparable data. And so the thought was, we have standardized instruments to measure so many health-related behaviors and data in health broadly. We lack it in sexual health and sexual health-related data. Maybe we need some sort of standardized questionnaire. The challenge of that, of course, being that there is this very strong feeling that we just can't collect these kinds of data in many contexts, and we can't do it in a comparable manner. So that was kind of the challenge set for us at the beginning. Is there a questionnaire? Is there a common set of core questions that we could have, that we could demonstrate, could feasibly be implemented in a variety of diverse global contexts? So that kicked off about 2-year process to solicit measures. We in September of 2019, we started an open call where we reached out to the sexual health community broadly defined. So this included population researchers, demographers, folks working in the reproductive health side, the maternal health side, the HIV/STI universe, and asked them to send us their measures, their existing instruments, the domains that they thought could be part of this core tool. Following that, with all of this pool of existing measures at our fingertips, we held a 3-day hackathon in January of 2020 in Nairobi, hosted by our colleagues at APHRC in Nairobi, to try to take that mountain of existing measures that were already in use and whittle it down to a brief survey instrument. That itself went through a series of technical reviews, including through our WHO colleagues here who work in the various domains that are addressed in the instrument, but also reaching back out to some of those folks who had submitted measures to begin with, and went through a series of refinement through then. And then we were left with an instrument that, from a theoretical level, had been developed that we could say was something that covered these priority areas, but we had no way of proving again that it could be implemented in diverse global contexts. And so that was where the primary research phase of this process kicked in, where using that instrument that had been developed within the global health community, we then decided to test it using cognitive interviewing, and developed a protocol in the middle of summer 2020. This was all happening during the pandemic, so it was an added level of complication, but also opportunity. And then after putting out a call for research collaborators around the world who'd be interested in working with us on this, between March of 2021 and March of 2023, through 3 subsequent waves, tested it, iterated, tested it, iterated, tested it again, and refined it. And that's where we are today. And you'll hear more about that research project a little bit later on. But my job is the questionnaire. And so I would invite you, if you haven't already accessed the questionnaire through some of the links available in registration, to take a scan of that QR code, and maybe we can also pop a link to the chat and go ahead and take a look at it for yourself. The questionnaire, there's a document that you've seen, and the questionnaire itself, if you want to scroll through as I'm talking some of the questions, that's available in Annex 1. And this is what's covered. There are 6 modules in the SHAPE questionnaire. We start off with personal information and health. That's information about the respondent completing it, sex at birth, gender identity, living situation, health status, etc. The second module is sexual health related outcomes for folks who work in population health and reproduction health more broadly. This is maybe the section that will seem most familiar. It covers reproductive history, STI testing and HIV testing as well as status. I will say that this is an abbreviated section. One of the purposes of SHAPE was to not reproduce health outcomes where there are established measures already. So this is not replacing a DHS module. It's meant to complement a DHS module on, say, family planning and maternal health outcomes. But this will be a section that seems a bit familiar. Something to point out is that we are collecting, after testing this and seeing that it is possible, we are collecting reproductive history of male participants as well, which I think is a really nice value add. Then we move to sexual biography, which captures sexual history related to any sort of sexual experience within, lifetime, last year, last 4 weeks, sexual orientation, as well as some hallmarks of, say, your experiences at first sex, including things like contraceptive use, whether that was a wanted or an unwanted experience, etc. Then we move into sexual practices, which is our chance to try to understand the sort of wealth and the spectrum of sexual experiences that a respondent may have engaged in, either recently or in the longer term, and also captures areas of related to sexual pleasure and satisfying sexual lives. We move afterwards to social perceptions and beliefs, which is trying to understand from the view of our respondent the extent to which our respondent agrees or disagrees with certain personal beliefs related to sex and sexual and reproductive health and well-being, ranging from, the appropriateness of young people to access comprehensive sexuality education, to the respondent's comfort with, the idea of 2 consenting adults having sex, regardless of their orientation. And then finally, we have kind of what we consider a soft exit, which is a close down that's asking about socio-demographics. So we kind of close off the instrument with things that will, again, be a bit more familiar and broader, capturing things like education, marital status, a lot of these, which would be adapted based on existing measures used in the implementation setting. I'll also note at this QR code that the questionnaire is available in both REDCap and in an XLS form, which it can be used for things like ODK collect and other open source data collection mechanisms. So that is a QR code that you can go to if you're interested in either of these electronic data capture forms, and they will get sent to you via email. The purpose and use of this is we see it for use in two ways. One, as a global common set of measures that can optimize folks' ability to do cross-national comparisons, and also as a sexual health and sexual practices module for inclusion in broader health and demographic surveys. So in theory, if there is an existing broader health survey that is in place, we see this as being something that can be slotted in as a sexual health related module. At the same time, we also know that folks have different objectives. And so if people are doing a broader SRHR study, then these are measures that can be incorporated into existing survey instruments. So we know that several countries are lucky enough to have incredibly detailed sex surveys already in place that are really responsive to national priorities and data collection needs. So we wouldn't want this to replace that. We would encourage these questions to be incorporated in so that these settings can contribute cross-national data. And it's intended for the general population of a geographic area. So this has been tested among folks ages 15 plus. I think our oldest participant who participated in testing was in his mid-80s, which is very exciting. And so we know from 15 upwards, this is something that can conceivably be used across sexes, identities, physical abilities, and profession. The intended modality of this is ideally using a combination of CAPI and CASI. For those of you not familiar with this, CAPI is computer-assisted personal interviewing. And what it essentially means is an interviewer has a tablet or a computer in front of them and is reading the questions and then entering in the participants' responses. And CASI is computer-assisted self-interviewing. So any web survey is a CASI survey. Essentially, a respondent is able to read through and progress through questions themselves and respond. The reason why we encourage this is because this instrument has skip logic and quite complicated skip logic. And this has been feedback from our testing that even for trained data collectors who've been trained on the paper-based instrument, that it can be a complicated process to flip back and forth and figure out what the optimal route for their respondent is. And so CAPI and CASI, in addition to being a reflection of, where I think the health survey space is moving in general, is also just something that makes sure that our data collectors and our respondents have a seamless experience. That being said, in the SHAPE questionnaire, I've told you what our intended purpose, our intended use, and our intended modality are. We also discuss briefly variations and the implications of those variations being discussed. And that recognizes that, there are differences in research objectives, in infrastructure, in existing funding that's available that is going to result in real world decisions needing to be made to modify the target population or implementation modality. And I'll talk very briefly about one example at the end of my presentation. The last section that the SHAPE questionnaire has, and I'll say that this is maybe all of this together is about 20 pages separate from the question itself. So we do keep this fairly brief and high level. We talk about adapting and implementing the questionnaire. And this adaptation section outlines steps that should be taken by research teams who've decided that this questionnaire is something that they want to use and want to adapt it to their setting and conduct their research. What I will flag here is that because of what I said about us realizing that in the real world, people have very different research objectives, very different research infrastructure, we are not providing as part of SHAPE either an implementation protocol, sampling frames, or statistical analysis guidance, because we could never respond to the wealth of uses that we've already seen folks wanting to use this for. Our translation process for folks who want to use this in a different language from the English language base would be similar to what we went through in the adaptation and the testing process, where one or more translators adapt the questionnaire into the target language, also known as forward translation. This is reviewed by an expert review panel. A different translator translates the questionnaire back into the source language, that's back translation, and then there's a review. So this sort of harmonization process that allows people to make sure that they're implementing a translated version with fidelity. We also, I would flag, would say for folks who are implementing in English language as well, English across the world is not the same. And there is a utility in adapting it to make sure that the English used in the questionnaire is reflective of the English that would be expected by respondents. We talk about that in the perspective of testing and piloting. Just because this has been cognitively tested in 19 countries does not mean that it wouldn't benefit from testing, especially if adaptations have been made again to within the setting that it is intended to be implemented in. And when we talk about kind of the due diligence that needs to be done, we talk about training and sensitization that's needed on the respondent side and the data collector side. So we address briefly the several key factors that we can do to ensure respondent comfort and safety, which obliges data research teams and data collectors to understand legal and ethical considerations when implementing this instrument, encourages them to be trained on how to identify and respond to signs of participant distress. And we include an example of something called a distress protocol in one of the annexes. And also we highlight the fact that there are several safeguards built into the questionnaire itself in response to different experiences that participants may have. And that includes everything from, opt-in, opt-out questions and exit ramps for participants who may not want to complete certain sections based on experiences that they've had, as well as just reminders, again, basic due diligence in health research, where a data collector is checking in with the respondent. We talk about training on research teams, which will be the subject of Peter Rock's presentation, which look at relevant training topics for data collectors and ongoing supervision and support. And we'll talk a little bit specifically about values clarification and attitude training. The last thing I would flag is that we talk about the importance of, this needs to be adapted and the need for clear and detailed reporting about any modifications that have been done, as well as how this instrument has been used. I want to end in about 30 seconds talking very briefly about something that our colleagues at the University of Porto, Pedro Nobre and Ana Luisa Patrao, did. They tested in a real world setting an earlier version of the SHAPE instrument between June and October of 2023. And I flag this because it's a great example of, how you would adapt this to a context. They were able to benefit from a Brazilian Portuguese version of the instrument from some of our collaborators. And they did their own adaptation process using the English source questionnaire and an existing Brazilian Portuguese version. They, based on the funding they had and the infrastructure available, did an entirely web-based survey. That was a CASI example, so entirely CASI, an internet survey. And then they did a telephone-based survey in order to reach members of their population who had lower access to the web, including older folks. They had 2010 people who completed it and were eligible for data analysis. And what I want to flag to folks interested in SHAPE, because I will let them at a subsequent stage outside of this publish their own results and finding. But what was interesting for us was what people's experiences were completing the instrument. Response rates were quite high in the online survey, almost 80%, which we were delighted by. By contrast, the phone interview was down to about 12%, which is an interesting experience. Completion rate for folks who did agree to participate was very high, 85.5%. And most of those actually dropped off after the SHAPE, completing the SHAPE module. Our colleagues had added additional questions, and that seemed to not quite work for folks. And then importantly, completion time. On average, it was 17.7 minutes for the SHAPE modules, 16.6 minutes online, and 20.3 minutes off for phone interviews. I say that this is just a great example of what it looks like when you adapt to a new setting and deviation from intended modality. And we're very excited about some of this initial real world implementation data. Thank you. I'm going to stop here. I want to thank everyone. We have 3 full pages of acknowledgements in the SHAPE questionnaire because there have been that many folks who have been involved with this over 4.5 years. And we are just eternally grateful to everyone who is engaged in this process and has been a willing and generous collaborator. And I will stop there. Thank you so much, Vanessa. Back to you.
Thanks, Leanne. Thanks so much. I think that was quite illustrative of the lengthy, meticulous, and comprehensive process that this tool went through to where we are today. And part of that comprehensive process was actually doing some real world testing of the tool using cognitive interviewing. We did this study using cognitive interviewing as a methodology across 19 countries that included a mixture of low, middle, and high-income countries across the world. And Erin will tell us a little bit more about that right now. Just before going on to Erin, I though wanted to tell everyone, we're getting your questions. We're gonna keep track of them, and we're gonna try to address them towards the end of the session so that we can have a more, a better dialogue towards the end of the session. Over to you, Erin.
All right, can you hear me okay? Perfect. All right, so I'm Erin Hunter. As Leanne and Vanessa said, I'll be focusing a little bit on providing an overview of the COTSIS study, which was a global study we've been implementing over the past 2 years to cognitively test and refine the SHAPE tool. So you might recall from the introduction presentation that once a draft questionnaire had been developed through an earlier hackathon and Delphi method, we then embarked on the COTSIS study to explore how items on that draft questionnaire were interpreted by participants across diverse settings globally. Just give me one moment to change my settings here. All right. So before I get into the details of the study itself, I'd like to begin with a motivating example to demonstrate the utility of using cognitive interviewing as part of pre-testing a new survey questionnaire. So I'm going to read this survey question to you, or you can read it on your screen, and I want you to try to answer it in your own head for yourself, as if you were responding to the survey question. So we're interested in your lifetime exercise patterns. First, when you were 12 to 17 years old, how many hours a week of brisk walking did you do? And how many hours a week of vigorous exercise, such as running, cycling, swimming, or aerobics did you do? So just take a moment and answer it for yourself. All right, so if you are like many of the other adults that I have done this activity with, pretty quickly you realize that it's really hard to answer this question. I don't know what I was doing when I was 12 years old, but I'm pretty sure what I was doing when I was 12 was different than what I was doing at age 17. So am I supposed to be averaging this across the years? What does brisk really mean? And is my definition of vigorous exercise the same as yours? So we know bad survey items leave respondents frustrated and they generate bad data. So how can we avoid doing this in our survey questionnaires? Well, cognitive interviewing is a qualitative method to be used during the pre-testing of survey questionnaires to enhance our understanding of question validity and to rigorously identify potential sources of measurement error, as well as identify opportunities to improve items so that they are interpretable by respondents in the way that you intend. So during a cognitive interview, the interviewer asks the respondent a survey question from the draft tool that is being pre-tested. And after the respondent provides a response to that survey item, the interviewer then uses various techniques to further probe in exploration of what the respondent interpreted that question to be asking, how they formulated their response to that survey item, and then whether there might be any mismatch between the respondent's interpretation and the actual measurement aim of that survey item. So with that basic understanding of the method, I'll give you a brief overview of how we use cognitive interviewing in the development of the SHAPE tool. So the purpose of the COTSA study was to cognitively test the draft shape instrument in a variety of demographic cross sections of the general population. And this was to determine whether respondents were willing and able to answer the instrument's questions and whether questions are interpreted by respondents as intended. Research partners in 19 countries implemented this study, and this is representing all WHO regions. So you can see the country sites listed here, and we have those teams represented on the webinar today as well. So as a very high-level overview of the methodology of the COTSA study, it was implemented in waves, and you can see that in the image here on the slide. A few countries out of the 19 collected data in wave 1. And this was then followed by a period of synthesizing findings across the countries participating in that wave. And then we also held a virtual joint analysis meeting to further arrive at decisions for revising the tool based on that wave's findings. And then the next wave of countries conducted cognitive interviews on that revised version of the tool. And then this entire process repeated for a total of 3 waves. The countries that participated in waves 1 and 2 also conducted additional cognitive interviews along with wave 3, using the latest version of the tool that was available by that point. And so they were able to explore whether revisions made up to that time had improved the tool's performance in their site. All right, so each country team adapted a core protocol for their site specifically, and they followed a rigorous process of translation and back translation before beginning data collection. And Leanne alluded to that process during her earlier presentation. Each site was, oops, I have an auto advance on my slides that I didn't realize. I'll just keep going back. Each site was to conduct up to 32 cognitive interviews with some exceptions, but in general, up to 32 cognitive interviews with persons of the general population ages 15 and above. Study participants were to be proposively selected, aiming for approximately equal numbers across sex and age groups, and at least 10 participants from rural communities in each site. And then the sites that participated in the earlier waves that then wished to conduct a second round of interviews with that revised tool alongside wave 3, those sites conducted up to 10 additional interviews at that second time point. Now, during the cognitive interview, the interviewers used a semi-structured interview guide, and it contained the draft survey items of the SHAPE tool, along with some suggested probing questions. But then interviewers also asked additional non-scripted probes just as necessary, depending on how the participant was experiencing the survey items. And then following the interview, the study team completed this data analysis framework, and you can see a screen grab of it on the side there. And this was filled in. There's a row for every participant. And there's space to record the participant's response to the survey item itself, which was being tested. And then there are cells where study team members synthesized the data generated by scripted probes. And you can see, I'm not sure if you can see my mouse, but as an example, there's a column here for a scripted probe, and the study team is synthesizing the data that was generated from that scripted probe here. So we have a different column for each of those scripted probes, and then towards the end of the data analysis framework, the kind of later columns also provide kind of another section because there was a lot of spontaneous probing that was conducted as well. So these data analysis frameworks enabled us to chart findings in a way that really facilitated comparison across participants within and also across country sites. Now, what have we learned across 2 years, 19 countries, 3 waves of data collection, 3 very large joint analysis meetings over many time zones, and over 600 cognitive interviews. We have learned that there are a lot of ways to interpret the very same survey item. So we really had our work cut out for us. Based on the COTSA study findings through the cognitive testing, we made a lot of revisions to item wording and structure, as well as response options and ordering of the items and modules themselves in order to improve match between the participant interpretation and our items' actual measurement aims. We also had to remove some items that continue to test poorly across sites, despite our multiple attempts at revision. And that was because, you know, we just had sizable evidence that those items were generating very noisy data and should not be used. You know, conclusions should not be based on data that would be generated from those items. So they were completely removed from the tool. Our findings also led us to add more informative preambles at the start of sections or modules, as well as improve some skip logic in order to be more sensitive to the participants' experience moving through the questionnaire. And this was particularly important for participants who had experienced non-consensual sex. So that's, you know, another example of how findings, yes, contributed to changes in items themselves, but also kind of our organization and recognition of kind of more detailed and informative preambles to walk participants through what might be coming in a subsequent section and why certain questions are being asked. Our study findings also informed the development of implementation guidance. And so those are the implementation considerations that you'll find in the pages preceding the tool itself in the publication. Our findings also informed our writing of translation and adaptation notes that accompany the tool. So you'll see some specific notes alongside items where there might be some ambiguity in the source language in English. And so we've provided some extra information for those sites who will ultimately translate or adapt the tool for use in a different language. COTSA's findings also informed some revisions to improve the tool's inclusivity while maintaining interpretability across the general population. So to give you just kind of a tangible example of what a change might look like that came about from the testing, this is a very kind of simple example, but good for illustration purposes. You can see on the left column the original item draft that we inherited at the beginning of the COTSA study to begin testing. The question stated, "Are you at present?" And the response options were single, married, separated but still legally married, divorced, or widowed. During cognitive testing, we found that many participants across multiple sites were interpreting this question to be about relationship status in general, rather than registered marital or civil status, which was the original item's intent. And because of this, unmarried participants, participants who had never been married, would not endorse the single option, even though according to the original measurement aims, that's kind of the response option that was intended for those folks. And so this was resulting in really high non-response across multiple sites. I won't go into all the details. There were several different factors that we found might be contributing to this particular interpretation. One being kind of where the item was sitting in the tool originally, around some, they've just been introduced to the fact that they're going to be starting a survey questionnaire around sexual practices, and we're talking about relationships, and so it wasn't surrounded by other sort of standard socio-demographic questions that individuals might be used to. Oh, right, they're just like asking kind of these basic socio-demographic questions. So it was their kind of frame of or their perspective was sort of influenced by the questions around it. So what we ended up doing is moving this item to the sociodemographic section at the end of the questionnaire. We changed the stem of the question to very explicitly state it's asking about marital status. And then we changed the response option single to be never married. And we also added a translation or adaptation note to this item to help teams who do plan to use this in your setting to ensure that it's most appropriate. I'll give you an example of what that could look like. So the translation adaptation note kind of recommends recognizing that in some countries, there are official or legal registrations of relationships other than marriage. And if that is the case for your setting, then it could be appropriate to change the wording in this item to incorporate those other types of registration. So an example could be on the right side, what is your marital or civil partnership status? So again, that it would only be kind of adapted that way if a civil partnership and that terminology is that exists and that is kind of widely recognized in your setting. So I hope that gives a little bit of a flavor of all the work that went into testing and revising the SHAPE tool. We'd be very happy to answer questions about that at the end. And I'll just close with some acknowledgements, the Global Coordination Team, the Study Steering Group for COTSIS, and of course, our research partners across 19 countries who did a tremendous amount of work over the past couple of years. Back over to you, Vanessa.
Thanks so much, Erin. And thanks for walking us through the whole process and how and what cognitive interviewing is and how we used it to actually come to this last version of the tool, which required a lot of testing and in different waves and coming to the final tool today. I just want to make sure everyone knows we're taking note of your questions. The ones that are content related, we're leaving primarily for the end for when we have the Q&A on the presentations, and we're trying to address the ones that are more related to troubleshooting as we speak. So now we heard about the implementation of COTSIS, as we called it, the study that we implemented across 19 countries to test the tool. And I will now hand over the word to Dusita, who implemented this or tested this tool using cognitive interviewing in Thailand, which is one of the 19 countries that participated. And I hope that by listening to her experience, you'll learn a little bit of what the process was in terms of trying to implement the tool and do the cognitive interviewing and implement the tool in one of the countries. Over to you, Dusita.
Thank you very much, Vanessa. Let me share my screen. Okay. Good evening from Thailand. I know that in some part maybe good afternoon, good morning, but here is good evening from Thailand. And greeting to all COTSIS collaborators and participants around the globe. It's my pleasure to be here, and I would like to extend my sincere thanks to the WHO for providing this opportunity for me to, as a representatives of my team, to present our COTSIS study in Thailand. And here I have the name of my team, Professor Suriporn Phanphung. I think she is online here with me today as well. And Kun Nipon, Mr. Nipon Daravutimapakon, Narimon Jalernchai, and Atakon Somwang. They are all the team of Thailand conducting this survey. I will not go into detail of the methodology because Ellen just covered everything already, but just want to briefly talking about what we have done in Thailand. In Thailand, we have completed 2 rounds of data collection. We have started in wave 2 and wave 3. And in the first round, which is in wave 2, we have done during July to August 2022, and we we have 32 interviews. In the first round, we go to 3 regions plus Bangkok, and we use the survey version 16. And in the second round, which is in wave 3, we have done in early this year, January to February 2023. And we conducted 10 interviews in Bangkok using the survey version 17. Here is the detailed breakdown of the participants that involved in our data collection in the 2 rounds. Altogether, we have 42 from the 2 rounds. I would like to make note here that we have 8 participants who identify themselves as the sexual diversity and diverse sexual and gender identities. And also we have 2 participants with limited literacy skills that have faced difficulties in doing the self-administered modules. So for these 2 cases, we cannot use the modality that we plan and normally plan for the tools, which is the self-administer some part and the interviewer administer some part. But for these 2 participants, we have to do the whole every modules with the interviewer. In the findings today, I would like to focus only on the respondent feedbacks in terms of acceptance and the feasibility of these tools. That I will go to all the modules of the survey version of 16 and 17. It is very important to mention that the data or the finding that I'm presenting today is concerning to this version 16 and 17 of this instrument. So it's not the final shape instrument that we are going to use from now on. And I'm confident that the final version is already improved a lot. Let's go to the acceptance part of the module A. The module A covers socio-demographic, some questions on socio-demographic and health topics. In the first version, our participants generally reported that questions within this module were straightforward and accessible. The level of ease in understanding is crucial in ensuring that respondents from all backgrounds can provide their input without feeling overwhelmed or confused. However, we did encounter some clarity issues because in the versions, certain questions were highlighted by participants as lacking clear definitions, particularly those related to sex and the measurement of frequency regarding cohabitation with a partner. For example, the question about intersex variations prompted one respondent to comment that while the question was simple, the subject could be sensitive for some individuals. And the confusion on the cohabitation is about how they point out the ambiguity in what number of times of cohabitation mean, whether it's referred to the number of days or number of people they live with. Module B, in our examination of the acceptance of Module B, which deals with the sexual health outcomes, we have come across several key observations that will inform our approach to future surveys. First, there were feedback regarding the placement of this module within the survey. Some participants found it quite awkward for them, especially when discussing the topic like pregnancy with individuals who are not yet sexually active or do not identify as heterosexual. Respondents identifying as LGBT highlighted the inapplicability of questions regarding efforts to get pregnant. We also have some issue in this module that the participant reflect that it's quite sensitive, particularly those concerning to HIV, STI, and experiences of sexual assault. Participants expressed discomfort and suggested us to consider moving such questions to self-administered section of the survey. And they think that this adjustment could create more comfortable environment to share personal and potentially distressing information. The interviewer's approach was identified by some participants as a factor that could notably influence the responsiveness. But at the same time, a considerable number of participants also reported that the interviewer greatly assisted them in understanding the questions and enabling them to provide more accurate response. Next one, I would like to talk about Module C, which deals with sexual biography. This module has been recognized for its comprehensiveness, covering all necessary questions without any identified need for removal. However, some challenge did arise, particularly concerning to the partner count. Participants expressed difficulty in reporting the number of sexual partners. This difficulty stems from both discomfort with the subject matter and the challenge of recalling specific numbers. For example, one participant noted that while the question wasn't difficult, finding an accurate answer wasn't straightforward. Another found it's easier due to having fewer partners to count, but acknowledged that those with more partners might struggle. The module also touched on sensitive subject of sex work, yielding diverse response. Questions about exchange sex for money or other commodities were met with mixed feelings. One participant expressed that while they personally did not feel negative about the question, it could be too sensitive for others due to societal views on sex work. Next module, Module D. In our study, we found that some participants encountered several challenges with this module. The question structure, particularly the complexity in skipping patterns, was difficult for some participants, especially when completing the survey independently or we doing this module by self-administered. This feedback indicates a need for a more intuitive design that allow participants to navigate the questionnaire with ease. Additionally, the length and complexity of some questions were points of concern, with some respondents reporting confusion and hesitation. Personal questions, particularly those concerning solo masturbation, were met with discomfort due to their intimate nature. For instance, participants expressed difficulty recalling specific instances due to infrequency, while participants felt discomfort with the topic highlighting a prevalence of questions related to partner activities. Module E, we tackle the subject of social perception and beliefs. This part of our survey was generate diverse reactions as well. One issue that arose was response confusion. Participants were uncertain whether to respond with factual information or personal opinions. This highlights the importance of providing clear instructions and where an interviewer intervention may necessary to facilitate understanding. The significant point of feedback related to the inclusion of diverse perspectives. Questions that were predominantly focused on heterosexual norms by stating men and women were found to exclude or marginalize the experiences of LGBT participants somehow. This feedback is invaluable as it directs us to ensure our survey questions are inclusive and reflective of societal segment. Understanding the diverse viewpoints of these subjects is crucial for a comprehensive analysis of social perception and beliefs. The last section, the last module is on identity and rights. Our participants found that the question generally straightforward. However, they encounter challenges with concepts such as discrimination, sexual orientation, and gender identity, which are critical but complex. This difficulty has highlighted potential inaccuracies in self-administered responses due to misunderstanding of these terms. We noted a sense of redundancy felt by participants regarding questions on sexual orientation and gender identity. These topics were seen as repetitive and sometimes caused confusion about their meanings. Another key point was the relevance of certain questions to heterosexual participants. Some felt that the module was less pertinent to their experience, like you see in the quote that I put in this slide. In terms of feasibility, I would like to highlight here some critical factors that regarding the cultural appropriateness and logistic considerations. First is cultural appropriateness is the paramount in the Thai context. The survey is generally suitable, but it's important to note as well that sensitivity required when addressing sexual behavior in rural areas where such discussion can be taboo. This is especially true in Muslim communities, where certain questions may be considered inappropriate and may go unanswered due to cultural norms. The time and effort required to complete the survey in Thailand must also be considered. The length of the survey, coupled with the need to alternate between self-administered and interviewer-administered formats, can significantly increase the time needed to obtain the complete data, which can affect participant willingness to engage thoroughly. When it comes to cost and resources, the survey's extensive nature and sensitivity of the topics discussed imply that interviewer-administered surveys are preferable for Thailand. This approach, however, incurs additional costs both in terms of financial resources and time commitment for both interviewer and participants. The challenges are complex. Participants with illiteracy or low educational levels may find survey particularly challenging. Additionally, the translation of specific terminologies into Thai presents its own set of difficulties. Some terms used in the survey do not have direct or simple equivalents in Thai, potentially leading to comprehension issues. This is most pronounced for participants with lower education levels or those from rural areas. In conclusion, I think the key findings summary is like I just said, that the cultural and linguistic challenges is important to note and maybe need to improve if we want to do the survey. The challenge intensified by diverse demographic and community groups within our study. Acceptance of the survey content varied widely among this group, underscoring the importance of cultural sensitive approach. Given this insight, we propose for Thailand that we must enhance cultural and linguistic appropriateness in our translation to ensure that all participants can understand and relate to the survey questions. Tailoring survey approaches to suit different communities will likely improve engagement. This means adapting our methods to be culturally and contextually relevant. Exploring more efficient survey formats could help reduce the burden on participants and lower the overall cost. This includes simplifying questions, reducing survey length, and utilizing digital tools where appropriate. Lastly, I would like to acknowledge to extend our heartfelt thanks to Emeritus Professor Dr. Apichat Jamrat Littilong, whose technical consultancy have been invaluable in guiding our study. Our team, field recruiters in the northeastern, the southern and Bangkok have played a crucial role in gathering the data. And also we owe a debt of gratitude to the 42 participants who shared their time and perspective. And lastly, I would like to acknowledge the additional funding provided by the Institute for Population and Social Research at Mahidol University. And this support was very important to our data collection process. Thank you very much.
Thanks so much, Desita. That was really great to hear about the experience of testing the tool in one country. As you could hear from Desita's presentation, we learned a lot of things from the respondents in Thailand, and these were collated together with the broad set of responses from the other 18 participating countries so that we could arrive at the final tool that we are launching today. You will also have noticed that that the order of the modules that Dusita presented is different to what Leanne presented earlier. And that's just an example of how we incorporated the lessons learned from the feedback that we were getting from respondents during cognitive interviewing to really come to this last version of a tool. So it was a very exhaustive process of bringing together qualitative data from over 600 interviews across the world and coming up with a harmonized tool, which is the one that you can now access through our website. So thank you, Dusita. That was really excellent. I wanted now to bring the conversation back to actually the process of implementing this tool and the adaptation and some of the issues that we learned from during the implementation of the study to test the tool, which revolves around strengthening research teams' capacity and making sure that the researchers that are involved in implementing this final tool, the tool called SHAPE, are familiarized with the topic, are familiarized with the tool itself, but also that they're granted opportunities to really delve deep into the subject area and understand the sensitivities that can exist around it, some of these issues in different settings. So Peter Rock will now present on the specific experience. They were an implementing partner, but they are also a research capacity strengthening hub for the HRP Alliance, which is part of our department here at WHO. And they have collaborated very closely with us in trying to support research teams during the implementation of COTSIS to make sure that the teams were had the tools necessary to be able to implement the tool. And this is one example among many, but we wanted you to hear from Peter Rock on how the team at APHRC was able to support us in the implementation of the study. So over to you, Peter.
All right, thank you, Vanessa, for that introduction. For those that may be coming in a bit late, my name is Peter Morioki, and I work with the African Population and Health Research Center, which is an international research policy organization that is Africa-based and African-led. And it has a footprint currently in 35 African countries. And we were, of course, one of the sites that were involved in the implementation of the COTSIS study. So we piloted the SHAPE in this country. But today, I'm not going to talk about how we did it. I'm just going to talk about how we prepared research teams, our own research team, as well as research teams in about 17 countries, 17 of the 19 countries that were involved to collect data. We understand that this tool, of course, collects sensitive data on sexual experiences and practices, and we prepared them through conducting what we call the value clarification and attitude transformation training. And to start off, just explaining, or rather saying that value clarification is that process of examining one's basic values and, of course, reasoning, so that one can understand him or herself and discover what is important and meaningful. And this is according to Maslow. And just to define a little bit, an attitude is that view or opinion that can be informed by values and beliefs, and can be informed by many things, including the way people are brought up, their culture, religion, and many other factors. And the reason why we factored on this is that values and attitudes can actually be very core in some behavior, in some human behavior. It can make people be less empathetic in some situations, and it can also change or alter the way people relate with each other. So attitude transformation, or the changing of attitudes towards something, is a logical outcome of value clarification. And the end point is that people are able to act according to how their values, or according to how they have affirmed their values. And the process is a three-part process, the process of value clarification, and it starts with choosing. And choosing is about choosing a value really without any kind of pressure, and understanding the pros and cons of that choice. And the second part is about pricing that chosen value, because again, it is associated with some level of cost satisfaction, affirmation, and confidence. And lastly, that part is to act repeatedly based on that freely chosen value. And then we hope that at the end of it all, it will lead to a positive outcome. And I'm going to show you what positive outcomes those are just later in this process. So why did we, or why should anyone conduct a value clarification and attitude transformation, especially when conducting research of a sensitive nature? And I bring to you the continuum, part of the continuum of support for sexual, reproductive, and health and rights. And this includes, at the beginning, people might actually be obstructing. And this, I'm just going to give an example so that you can understand even this figure better. Let's talk about a service provider who provides sexual and reproductive health services. And at some point, based on their values and attitudes, they can actually obstruct the provision of values, the provision of services to some people because of what they believe. And this could have been shaped by culture or religion, as we've spoken before. And it moves, the process of value clarification and attitude transformation moves a person, this could be a service provider, this could be somebody who's conducting advocacy or a researcher, from obstructing to tolerating, from tolerating to accepting, from accepting to support, and from support to advocacy, or to providing service. So that person who was obstructing service provision at some point, eventually, if the VCAT process is successful, they will end up providing services, not because they've been forced to, but because they have come to some realization, maybe because of some new repackaged information, or they have had some information that they have not had before, or they have participated in activities that they have actually come to recognize that some of their values and attitudes will usually be able to hinder them from providing the support that is required. So the general objectives of a value clarification and attitude transformation is to identify from the participants the current values that they hold dear. And these are towards sensitive and contentious issues in SRHR. And at that process, they're supposed to describe what are the alternative values. Should I continue to hold on to these values? Or are there alternative values that I can actually embrace? And of course, what are the consequences of those new values or alternative values? But in particular, and especially for COTSIS, we wanted also participants to be able to distinguish between what are the assumptions, what are the myths, what are the realities about some of these contentious issues. And these are issues to do with unwanted and unplanned pregnancy. It could be issues with abortion. It could be issues with LGBTQI plus issues. And of course, people who experience all this. And at the end, we wanted our participants to be able to demonstrate some kind of empathy towards women, families, individuals who experience injustices or even stigma, and healthcare workers who also work in providing services in SRHR. And also be able to demonstrate a separation of your personal beliefs from your professional role and responsibility. For instance, as a medical doctor, separate what you believe from what your role is as a professional medical doctor. If your role is to provide her services, then we should look at why would you not be able to provide such kind of services, and then try to move from, as we saw from the other figure, from obstruction to the provision of services. Now, just briefly, because we were also, Kenyan side through the African Population and Health Research Center was involved in validating this tool. So we tested this in 3 demographic cross-sections of the Kenyan population, in a rural society. Then we also did it in an urban society, and in urban society, we divided those into 2. So we had lower income, and then we had a middle income setting. And we conducted 2 rounds. The first one involved about 34 individuals, and the second one, which is additional testing, involved about 10 individuals. And we ended up with about 44, we ended up with 44 individuals from 15 years and above, and of course, from different ethnic groups, from different gender identities and sexual orientation. The 2 rounds were conducted between July 2022 and March 2023. And just how does VCAT and SHAPE, or rather COTSIS, how do they relate So we understand, or rather, VCAT deals with sensitive and contentious issues in SRHR, such as abortion and sexual orientation and gender identity and expression and such matters. And also now the COTSI study, during the COTSI study, the data that was being collected on sexual experiences and sexual practices were related to the same topics. And so that is how they connect with each other. And so the VCAT process actually enriched the conduct or the implementation of the COTSI study. So generally in our site or in our sites or in the Kenyan site, most participants displayed a good comprehension of the terminologies of the translator tool. We had to translate the tool from English to Swahili because Swahili is the most commonly used language in Kenya, and it is one of the two national languages. And the tool was generally accepted, but of course there were varying levels of comfortability and acceptance. Just to inform that in the Kenyan context, there is poor acceptance and criminalization of the same-sex relations. And it was just this year, I believe should have been in February of 2023, that the Kenya Supreme Court allowed the National Gay and Lesbian Human Rights Commission to be registered as a non-governmental organization. And according to their judgment, the Supreme Court judges mentioned that it would be unconstitutional to limit the right to associate through denial of registration of an association purely on the basis of sexual orientation of the applicants. And so, in the context of having poor acceptance and criminalization of same-sex relations, you understand that we had to do of the value clarification and attitude transformation so that even our data collectors plus our research team could actually be informed about how to proceed. Now, so we conducted training, or the VCAT training, in 17 out of the 19 countries, as mentioned by Erin. And so the only countries that we didn't conduct VCAT training with was Botswana and Italy, because they had their own ways of doing the value clarification and attitude transformation. And so we took the research teams through this. And just to mention that in December of 2021, just before we started our implementation, the APHRC research team, and I can see almost all of them are online, including our PI, Beatrice Minor, there's Kenneth, and there's Emmanuel. We went through the VCAT as participants, and then 3 of us went through the VCAT training as facilitators. And so we were trained as participants, and then we were trained as facilitators. And the reason for that was that we would be able to train our own data collectors once we brought them on board, that we will be able to conduct this training by ourselves. And around January 2022, we started the training for the country teams. And in January, we conducted the VCAT training in 8 of the Wave 1 countries, or with the research teams from the 8 of the Wave 1 countries. That involved around 25 participants. In April of 2022, again, research teams from 6 countries, from the Wave 2 countries then, and we had about 21 participants in that. And in June, we did a training that involved 15 participants that was concentrated with the Francophone countries that were collecting data using the French language. Now, I want to bring you some experiences of training the research teams on VCAT. So when we trained our research data collectors, rather, or research assistants in July of 2022, the main issue that we trained them on was to respectively and in a judgmental way engage with the respondents around sensitive SRHR topics. This could be people that would have been, would have undergone either abortion, or people that belonged to the LGBTQI community. And we did several activities on that, which I'll mention as we move on. Then we aimed to have them, increase their knowledge, explore their own individual attitudes and beliefs that would potentially act as barriers to collecting data. And then that would, of course, negatively affect the outcome of the COTSI study. And the first activities that you can see in the first photo there, it is called like cross the line. And, would have activities of, say, a statement, and then would say, if you have not experienced such an issue, then you cross over onto the other side, and then would have both sides talk about it and, bring out the issues. And then in the second example, we had different groups, grouped together, and they would discuss about any kind of issues that were controversial in their bringing up and all that. and that would help them to even come, to some consensus. And then, but more specifically, we wanted them to explore and clarify, some tensions that would exist between their personal beliefs and professional responsibilities on these sensitive issues that we're talking about. Now, we used different training approaches. First, we had some video illustrations that were meant to dispel myths and provide a global context of challenges faced, of course, by women that had undergone, abortion and LGBTQI community. And participants would share their personal experiences on the same. And we also provided empirical data that actually that shows that in countries where there are restrictive laws, and especially around abortion, you find that there are more cases of unsafe abortion. And the different activities that I mentioned were meant to address the different beliefs, societal and individual attitudes, and also values about how these things hinder women, girls, and the LGBTI community, people from exercising their sexual and reproductive rights. And some of those, activities were playing something that we were calling the terminology game, the ideal man or woman, reasons why people do things. And some of those activities were eye-openers in terms of how people relate with different people from different communities. And we also did our pre and post service, and we assessed, change in knowledge, attitudes, and behavior. And we are going to see some of the things that came out. So after showing a video on to dispel myths around people that experience abortion and the LGBTQ community, we would ask a question from the participants, what stood out for you from the video? And then, these are some of the responses that they said, that backlash against the community is quite shocking and severe. Advocating for these rights requires courage. There's so much hate in the hearts of men towards one another. And the main character in the video was called Kasha. And some people would say, they understand why Kasha would be traumatized. And some of the other questions would ask is, what does the video reflect about the power of culture and religion? And as you can read, some of them would say religion is against religious intolerance, yet most people who are religious are actually intolerant. And other questions would ask was, what values or teachings exist in your culture or religion that could be used to support respect and equal rights for LGBTQI plus people, and also people that would choose to go through abortion. And just to read one of them is that human life is sacred and people should practice tolerance and love. We also asked participants how was the workshop, and they would say it was very helpful to face the issue and discuss about it. And then the most important thing, it will help me prepare for the actual interview and how to react when faced with this issue. So some of them found the training very useful in the sense that they were also able to see things from a different perspective. So they brought their own perspectives, and then other people shared their own perspectives, and they were able to learn from each other about that. And we also asked them how they would incorporate what they learned in VCAT into the course study. And just to read just a few, because of time, they would say, my body language, tone, or reaction might unconsciously show my disagreement or judgmental attitude. And so that would be one way to either intentionally or intentionally show that they're undermining, the rights of people that have gone through different situations. And then we were asking them, given that their role as researchers in the course study, how would they do to advance these rights? And just to read one that said, to be open-minded towards women who seek abortion services and, the LGBTQI plus community. Some lessons that they mentioned that they got from the training was that, I have learned to perceive people without bias or being judgmental. And that is just one of the endpoints of value gratification and attitude transformation, not to be judgmental. And as a researcher particularly, you need not to be judgmental, because for you to collect data, you need to collect it in a kind of a neutral lens without being judgmental from the people that you're collecting data from. And then some of them mentioned the new knowledge that they had gotten from the VCAT workshops, a platform of learning new concepts and evolving terminologies about sexual issues in the world and aspects among the different people's perspective. And then in terms of capacity strengthening, somebody mentioned that I would like to have the material from the workshop and replicate it with the team. And we were able to share most of these things with the participants. Because remember, some of them were research teams, and in those trainings, they hadn't yet recruited their research assistants. And so we actually shared the material so that they would be able to replicate the training with their own teams. So now, in 2020, we established as EPHRC a virtual academy that offers online and blended courses as part of RRCS. And the VCAT, the Value Clarification and Attitude Transformation course, is available as a blended course on the virtual academy. And this was because we wanted, we want this training to be available to a lot of people. We validated this training through 2 offerings, one in May and one in September, and we had 16 participants in each training. And so it's a validated course. And we currently offer it free of charge, and participants, of course, get a certificate of accomplishment after successfully completing the course. And I would like to acknowledge the HRP for the funding. I would like to acknowledge my colleagues, all of them listed here. I think most of them are also online, and the interviewers and study communities. And we also interacted and worked a lot with the blended course with the 2 participants, or 2 rather consultants from IPAS. That is Maury Gonzaga and Eric Mundia, who were our trainer or our trainers or our specialist trainers who were able to train us so that we can be able to train others. Vanessa, over to you.
Thanks so much, Peter, and thanks for providing us a very comprehensive outline of how we address some of the needs, the training needs from our teams during COTSs, the cognitive testing of the tool. We are running out of time. We have 9 minutes left of today's webinar. And in the interest of time, I think we have been reading and trying to answer some of your questions as they came along. And I've tried to group some of them together. I will go to Leanne first to address some of the questions relating to what is the study and what is the actual tool and what we hope to get moving forward. And then if we have enough time, I'll go through the rest of the panelists. But I think Leanne put both her and my email in the chat. So if we don't get to address all of the questions, please feel free to contact us over email, and we'll make sure to try to provide an answer the best of our ability. So over to you, Leanne.
Yeah, and for the purposes of the recording as well, I would say questions related to this should go to HRP Alliance at who.int. So if there's anyone who has questions following this and doesn't have access to the chat, HRP Alliance at who.int is an easy way to get in touch with us. Very quick points about, I know we had seen these in the chat, ethical issues addressed in the questionnaire are done so in section 4. This is for a colleague Yosef in there, so please check that. I will flag that again, this is not, what we are not doing is providing a kind of a survey methods or best practices textbook in this, because this exists and we know that you as researchers around the world have access to these things. So we're trying to flag things that would be specific to implementing this questionnaire, but you can find some answers there. And then for Entourage as well, the switching from in-person to self-administered, we don't have a ton of time for that now, but I would say if you go into the questionnaire, at the beginning of module C in Annex 1, you'll see some template text that we provided that shows what a transition of switching from interview-administered to self-administered might look like. And of course, that gets adapted for whatever setting you're doing this in.
And that could just look like handing the tablet over to the participant if you're using a tablet, for instance.
Exactly. But again, adapted to whatever you're dealing with in your setting, but we've provided some text that we tested. The thing that I want to flag, and it's a second question that Entourage asked, but I think is also a bit of a recurring theme here, is the fact that we've done a retrospective for you today. We've shown you what it took to get to this point. And now it really, this is the part where we say over to you, colleagues, because what we have is an instrument that we won't even say is globally applicable, but we've tested it in 19 countries in intentionally very, very different settings and with different populations, different languages, different predominant religions, different regions of the world, etc., to say there is reason to believe that this can be done, even in settings where we thought, oh no, this isn't, culturally, this is not what we talk about. But there is still an onus on researchers who want to use this to adapt it and make sure that they're not immediately implementing, you know, this among a population of 2,000, 10,000, et cetera, but that they, of course, confirm that in their settings. This is part of why we are collecting on that short form, that data call form, where we say, you're welcome to access the REDCap and XLS form. It's why we're asking those short questions, because to Anjaj's other point, we want to know who is interested in using this and where we can make linkages and where we can offer technical support as WHO. We want to do that. We want to be in an environment where folks are talking to each other, where they're looking at data across similar contexts, where people can share and collaborate. We think that that will strengthen data in this space. So that is why we are collecting those data. We know that not all of your settings are captured there in that country list, and we've tried to address some of those questions individually. I'm also going to work with our IT department to make sure that we can add additional specifications. If you don't see like a country affiliation that makes sense for you, it is not a required field for the moment and will not be one. So please make sure you indicate where you are from in the text box, and we will make sure that we can engage with you appropriately, and also that you're connected to people in that space who are doing similar research. I'll stop there.
Thanks, Leanne. We do have 4 minutes left. So I think I wanted to send over a question to Erin. There was a question around testing the tool with only 42 participants, whether that would give us a good picture of the country. And I think this is more of a methods question for you, Erin, if you can address that.
Yeah, I mean, of course, more, it would always be better. We would, like to be able to speak to, unlimited numbers of individuals, but, previous cognitive interviewing studies have used kind of similar sample sizes, and we found that you can actually identify a large number of errors and make significant improvements even with sample sizes within that range. So we're certainly not saying we found every possible issue that could exist for any type of participant. We're kind of doing our due diligence the best we can within certain constraints, but this is very much in alignment with other approaches to cognitive interviewing. And yeah, you'll be surprised how quickly you can start to see patterns in kind of misinterpretations or blatant errors that we made when drafting the tool, and we could improve from there. So great question. Happy to talk more about it offline as well.
Thanks, Erin. And yes, as Leanne said in her presentation, this we presented the tool, but this is not the end all be all. We do ask that you then adapt and test and make sure that the tool is relevant to your setting. So thanks for that, Erin. Perhaps one last question, and one for Erin and one for Peter Rock. For Erin, maybe you want to address the issue around why certain modules were moved around. What is the difference between the different modules? Just very briefly, I think that might be helpful.
Yeah, so sometimes modules or certain sections were moved around because of the influence that other items or other modules would have on kind of creating a particular frame of reference and impacting the way participants were responding or feeling comfortable talking about something, having just claimed that something else is true for them. So I'm speaking a bit kind of in ambiguities, but again, would be very happy to talk about that in more detail offline when we have a little bit more time. Particularly, if we're asking about certain practices and then also asking, perhaps what religion somebody identifies with. And you can imagine kind of the influence, the order of those questions might have on how somebody feels comfortable responding. The really quick question about difference between the module on sexual biography and the module on sexual practice. The sexual biography section is more so questions around sexual orientation, age at first sex, number of sexual partners over different time periods, etc. And then the sexual practice module is much more kind of specific questions around particular sexual practices, acts, like kind of when was the last time you participated in XYZ at your, Does that make sense? Am I being able to distinguish that quickly enough here at the last minute?
Yeah, thanks,
speaker.
Erin. And actually we posted the link to the tool in the chat a couple times, and you will be able to quickly browse and see what types of questions are in the different modules. We're at time, and I know people are already signing off. There were several questions around VCAT. Peter Rock, you now have a lot of work on your hands. There's a lot of interest on that. I think with Peter's presentation, you all kind of got a sense of where they're going, and I think you included an email address, right, Peter? So maybe they can just address those specific questions to you, and we can maybe add your email address on the chat, Peter. And in the interest of time and making sure that we close at the time we said we would, I would like to thank all of our panelists and the over 150 people that were connected at the height of the webinar today. And we really, really hope that you are able to use the tool, that it's useful, and please connect with us if you will be using it. We really want to hear from you. So thanks to everyone. Maybe we can all have a little wave goodbye, and thanks everyone. Bye now.
Thanks, everyone.